with you.
So thank you, everybody. It's wonderful to be here. This is really the product of many years of working with Sabrina and Jillian and others. I really appreciate the opportunity to talk about this work. So I co-direct the Larry Green Center. It's located virtually in Virginia and in Ohio, because I work with my buddy Kurt Stenge, who works at Case Western while I work at VCU. I am a cultural anthropologist by training. You'll hear me talk about primary care as if I'm a clinician. That's a weakness I have. I simply identify with primary care quite fully, so I tend to talk about we and us. I was asked to come talk to you today because of this survey we developed. So in the US, we have a number of issues we are trying to deal with. One is that we have failed over the course of decades to really adequately support primary care. And my group knows this all too well. So when the national emergency because of COVID was declared on Friday, March 13th in the US, we sat around a table quite frustrated about the fact that we knew there was no national database for primary care, no national research center, no national funder, no coordination of any kind, and primary care was about to be inundated by needs and a need for discovery, a need for coordination, a need for information, and there was no means to do that. So we, that day, actually sitting in a coffee shop, decided to launch the quick survey. And it happens weekly right now during the summer with lower volume. We are doing it bi-weekly. At lower times yet, we will do it monthly. We are responsive to the clinicians with whom we work. But the purpose of the survey is to gain an understanding of the natural evolution of primary care during this pandemic and the effect it has on primary care. For that reason, we started off with some very key and simple rules. The first is that the survey had to be flexible. It had to be flexible both in terms of how we fielded it, and it had to be flexible in terms of what we asked. That meant, to a certain extent, we were going to give up the idea of being able to follow the same cohort over time. We felt it was really important because COVID was changing week over week, and we needed to understand things as they were developing. It was just going to be a different approach as the weeks went by. The second thing we decided is doing this at a time when the primary care system is under a lot of pressure meant that we did not want to ask questions that we couldn't do anything with immediately. We couldn't make immediate use of the data. We weren't going to ask about it. It wasn't respectful of people's time. That was for data collected about COVID, about their response to it, as well as demographics about them. And then the last principle was that we were going to partner with every organization that was willing, and we were going to disseminate our data. So in the US, we have very little access to the clinical data that is produced at practice levels. And so it was really important for us that we make the data easy to collect and easily accessible to participants. We've maintained that throughout and do that for all of our partners as well. The survey itself takes less than 3 minutes to complete, and it usually has some core questions that are about core things like levels of stress or use of telehealth. And then it has what we call a flash question, tongue in cheek, thinking of flash mobs. They're there, they're big impact, and then they're gone. It has a flash question that's informed by how things are changing over time. This was just a cute cartoon because there is a great deal of information that's collected that people feel like they're going to do something with over time, but they can't make any immediate use for it. That was one of the first cuts we made, was that we don't collect anything we don't believe we can make use of. The survey has been going for 17 cycles now. It's been about 24 weeks. This screen simply shows the number of different organizations here. Primary care is still quite feudal in the US, so the internists and the family medicine docs and the pediatricians, they don't always get along in the same sandbox. For me, primary care is everybody who delivers primary care, so it goes across all disciplines. It also goes across all clinician types, so we have physician assistants, nurse practitioners, as well as MDs and DOs. But we also get a fair amount of psychologists and pharmacists and behavioralists now as well. So I wanted to provide you some just sort of big lesson learning, and then I figured during the question and answer, you can ask me anything you want. We get not only the quantitative information, but we ask a fair number of open text questions as well. So we have some interesting stories that we are now able to share. So the first thing we noticed is that there is a new normal in primary care, and forgive me and my language, but it sucks. It is corrosive and it is debilitating. The first thing that I always point out is the level of mental stress. So 80%, larger than 80% of the clinicians in our health system say that they are experiencing severe mental stress right now. An additional 65% of those feel that their families' well-being is suffering as a result. We have clinician burnout is something that people talk about all the time. Almost half of our clinicians say burnout is at an all-time high. I'm not sure what the outlook looks like in Canada or what the workforce looks like. In the US, we have an older workforce and then kind of a gap and a younger workforce in primary care. So when they say burnout is at an all-time high, they're actually looking over a period of decades. It's pretty significant, and it's affecting, as they report, both their physical and their psychological well-being. The pandemic has been going on for a while. It's going to continue. One of the things that we ask is about the level of stress people are experiencing, and we want to understand that over time. It can be easy to lose track of what that really means. So in our latest survey, which actually just closed this morning, this is hot off the presses for you guys, we asked, how does the stress now compare to the stress during the first month of the pandemic? And you'll see the first two bars added together, it's about 30% say that it's worse and we're struggling. We are really having a hard time. Then in the middle, you'll see there's a bunch who are saying, you know, almost half who are saying it's pretty bad, but we've almost gotten numb to it. We don't even think to say it's bad anymore because it is now actually our new normal. It is an untenable situation. There are only about 16% who say that it's getting better. The others are people who didn't want to pick one of these options and instead wanted to say, in their own words, exactly how afraid and at the end of the ropes they were. The next thing then, in addition to mental stress, is financial viability. It's really suffering here. So our payment system is heavily dependent on fee-for-service, no matter how they couch it. It's heavily dependent on fee-for-service. And so when you have a system that's all about people meeting face-to-face and suddenly you can't, everything's going to tank. And that's exactly what we saw happen. There are many other results from that. And that's what I actually wanted to show here. So we have every 4 weeks, we ask the question about expired vaccines and medications. If people aren't coming into the office and we're relying on telehealth, we aren't able to deliver those vaccinations. And we routinely see about 15% of practices saying they actually have to destroy vaccines and medications that have been expired. How this happens in your setting, I'm not entirely sure. In the US, the practices have to pay for the vaccines and the medications up front and get reimbursed when they are delivered to patients. So this destroying is not only a loss of the vaccine resource, but it's also just money out the window for the practices. We have 13% that continue to say telehealth billing is denied. Again, the red numbers are actually updated with the survey that closed this morning. So this is over the last 4 weeks, not since the beginning. We continue to see about 10% every week reporting that they have staff quitting because we have a lack of PPE here that's pretty extreme. Still about 50% of practices report that they don't have access. It's interesting to me and sad that we have new clinician offers that are rescinded. So a lot of people finish their residencies at the end of June and go into practice, and those offers for work have been taken back. So we have educated a group and now have people with student loans, but no ability to actually earn an income. And then you'll also know that it's still pretty high, the number of practices that continue to experience furloughs as well as skipped salaries. In addition to the clinician survey, we've been doing patient surveys. We feel strongly in the Green Center that primary care is a relationship. And that means that you need to pay attention to all parts and all facets of the relationship and not simply one group's perspective. So as soon as we were able to get some funding, because it's harder for us to access patients, we started a patient survey. We've now surveyed about 7,700 patients. And there are some basic things that we've learned. For instance, in 2009, 42% of the US population saw a primary care provider. Consistently in our survey, every 2 months, more than half of the patients have seen their primary care provider and seen them more than once. So even though in our fee-for-service environment that privileges face-to-face, we have seen people go as far as 70% telehealth. We've seen telehealth billing denied. Fee-for-service is not happening because there isn't the face-to-face interaction. And we've seen a 500% increase in the amount of visits to practices. These are reported by the patients, not by the clinicians. It's very hard to get that information when you can't bill for it. What we asked patients what would happen if their practice is closed, because we are seeing a lot of closures happening here in the States. In my home state, in Virginia, we've had 450 practices closed since the start of the pandemic. Patients are actually downright upset about the loss of their physician. A third of them talk about it as something that would leave them heartbroken or feeling panicked. This is a trusted relationship that is not easily replaced. Another way for us to think about that is in relation to the current, really largest civil rights movement of our generation. In Virginia, we have a fair amount of activity. We still have riots every night, often peaceful protests. And it's unfortunately usually law enforcement here that seems to turn it violent. But what we noticed in talking to the patients as well as the clinicians is that this was a really good example of how comprehensive primary care is and how important the relationship between clinician and patient is. 86% of all patients believe that racism affects their health, and many of them were making appointments with primary care specifically to get help with physical, mental, and emotional symptoms related to racism. They had no other complaint. They were there because of what was going on in our environment. This is an extremely telling statistic. There's a third, so I talked about the mental stress and I talked about the financial strain on primary care practices. Part of the sort of natural disaster of COVID is that there is a new public health crisis that's brewing beneath the surface, and it's there now. We just have only begun to touch it. These are some of the issues, these are from our July 1st survey, that have started to rise. So even with practices that are still seeing low patient volume and face-to-face visits, we see that we have an increase in dental health issues, an increase in vision issues, a huge, tremendous increase in mental and emotional distress, and then health issues that are exacerbated by lack of access to care. So we have many patients that are avoiding practices because they think they'll get sick if they go there. We have many patients avoiding practices because they can't afford the copay, so they let things delay. And we actually have usually about 15 to 20% of patients who say they're avoiding practices because they believe they're busy and they want to give their docs a break, which is very sweet, but they don't understand it's hitting the bottom line. What we've noticed is a dramatic increase in health burden as a result. And practices are starting to get overwhelmed by that. We had a wonderful study done by one of my colleagues here, Steve Wolf. It was in JAMA in the US, and it showed that during the pandemic, we have had an excess 87,000 deaths in the US. That is 87,000 deaths during a 3-month period that is extreme or in excess of what we've had on average over the last 5 years. Conditions like diabetes have had a 400% increase in mortality. This is what it means when you don't monitor chronic conditions. Telehealth has been an important tool to help with that. It is not reimbursed very well. People debate this a lot. It should not be an all or nothing. People talk about telehealth is good, telehealth is bad. It's good for some things, get over it. So it's a tool that we can use, and it can actually increase access. 78% of patients say they just feel better when they can talk to their clinician. This enables them to do that. Unfortunately, when you change payment, this becomes an added burden and an added pinch point for access. So the most vulnerable actually live in areas where phones and computers or iPads may be their best way of connecting with their clinician. And when we cease to pay it, we see that the volume of offering those visits goes down. The clinicians simply can't afford it. So this is just tracking over time. And the gray bar is in-person visits, and you can see the other two, which are types of virtual care, they just go down and down and down as it continues to not be paid for or not be paid for over time. The last thing that I wanted to share with you in terms of the US results is that our practices say they're not ready for what's coming next. And I was actually just talking to a task force looking at changing primary care this morning. And the way I explained it to them was this: healthcare is our fourth largest industry in the US, and primary care is its largest platform. The largest platform of the fourth largest industry. And in 3 days, 50% of it changed the way they did business. And in 2 weeks, 80% of them had changed the way they did business. These are people who are used to adapting. They did it, they had to buy new equipment, they had to do new workflows. They've taken on 500% more work than they've ever had before. They did that and they were okay then. And now they're telling you they're not ready. This is really significant. They have no bandwidth left. So what does that mean? It means not only that they don't have the mental flexibility to take on new problem solving, that they don't have the bandwidth to adjust to payment and billing that changes here near about weekly now, but that they also are continuing to lack and feel the impact of not having basic things like personal protective equipment or the ability to get people tested or tested in a timely fashion. They aren't ready for the pent-up demands. They certainly aren't ready for the next wave of COVID, though 50% of them have seen an increase of COVID cases over the last month. And they are definitely not ready for the upcoming flu season. The reason I have video-based care and phone-based care in there is because many of our private insurers have stopped payment for those things, and I harass them about it any chance I can. So what we see here is really a fracture of a social contract. And what I typically say is this, and you guys already know this, but primary care is about having a clinician worthy of your trust. They acknowledge the wholeness of your dignity, the fullness of your person, and they put your interest above their own in helping you with your care. They do that understanding that society sees this as a basic good and is willing to invest in that basic good. What we've seen during COVID is that society has failed to deliver on its side of the bargain. That leaves us feeling like we're somewhere between lost and very lost. And what are we going to do? So one of the easiest things to do is collect data. So we collect data. I was so excited when Sabrina reached out to me about the interest in doing this in Canada. She's been a wonderful champion. We have partners in New Zealand and Australia as well. This is really important because it allows us to compare our findings across nations. That actually means across political systems and across payment systems. And it lets us understand what's about health, healing, and connection, and what's about policy, payment, and context. It's an invaluable resource to have. We share the findings broadly. Every week when we send out our findings, we actually also send out our data. So all of our partners get a copy of their raw data. We provide it for them in contrast to the national data. For our international partners, we provide them with their raw data. We usually are able to do that within 5 to 8 hours, depending on what time zone things are going on in. And then we share our findings broadly with policy, with media, with social media. We have had over 170 million impressions of all of our news articles and tweets that have resulted as part of this work. Our data has been used by every primary care professional organization in the US to write to Congress. I've presented to Congress during a virtual Capitol Hill meeting. We've had several states that have used this data to develop state-specific task forces to change the way primary care is paid for and managed. We've had about 200 news articles appearing in high-profile things like the Wall Street Journal and the Washington Post and the New York Times. It's been really nice to see. Thanks to our international partners like Sabrina, we have been able to get the word out in other countries as well. This is a global pandemic. It's not a national one. The only way we address that is to form broad-based coalitions and to free up our little feudal differences and to just share data freely and talk about what it means. And it's going to mean making some mistakes along the way, because COVID seems like everything all the time. It's only really been around for us for about 6 months. So we're learning. It changes, and that's okay. When I talk to policy folks, one of the things I talk about is how do we fix what's going on? And we have to do 3 things all at the same time. I know that's hard, but we do. We have to do 3 things all at the same time. The first thing we have to do is stop the hemorrhaging. So find ways to get resources out the door immediately to help the practices that are in danger of closing or don't have enough supplies. The second thing we have to do is stabilize the platform, but it has to start at the same time. We do that by doing a gap analysis. This is typical of any kind of disaster. You want to understand not just what happened, but were there aspects about you that made you particularly vulnerable and made the damage that was wrought worse because of it? We in the US actually have not done that yet. So we continue to not learn, and we continue to suffer. It's one of the worst, best experiments that anybody can see. So stabilizing means doing a gap analysis up front and then starting to address those issues. That's long-term solutions, not short-term solutions. The third thing is to strengthen the platform, and that really is about investing in infrastructure. We haven't done that here for about 50 years, and if we think primary care isn't funded, we should look at public health in the US. It's even worse. So we are trying to band together and work on that. For us, that really means investing in the workforce. Without them, we don't have anything. So clinician well-being is extremely important. Once you have a workforce in place and supported, you have to support its functionality. That means understanding what patients' needs are, what their expectations are, what their fears are, and figuring out how to meet them when and where. That's our job. And then the third is to have a long-term vision. It is very hard to make it through anything if you can't see the end. COVID isn't even a marathon. A marathon, you at least know where the finish line is. We don't. But what we can think about is there way stations along the way, and how can we understand those and help each other to see those so that we can continue to maintain that hope as we fight this very real situation. The last thing I would say is that it can feel like we're Sisyphus trying to push that big old boulder up the hill and it just keeps rolling back at us. That's usually what happens to primary care. But the interesting thing that I see in the comments is that it's not. There is an amazing resilience, and you see it across all the countries. It's one of the real fascinations I have. Does not matter what's going on in the politics, in the payment, you see an organic, united professionalism forming and a sort of re-understanding or reimagining of what primary care is and its mission and how it can further population health. And mitigate inequity. So this has been a real pleasure to see and a real privilege for me. I appreciate the time to talk to you guys today. I'm gonna stop sharing my screen. You'll have a copy of my slides, and I'm ready and happy to listen to what our panelists have to say.
Thank you, Becca. That was fascinating and really interesting results. Amazing the information you can get when you ask questions and if you ask the right questions. Okay, so now we're going to hear briefly from our panelists. I'm going to ask each panelist to introduce themselves. I will say their name before they start, but first we're going to go to David Dirksen, who's a patient partner. So David, do you want to briefly introduce yourself? And I believe you have a few comments to make, and then we'll go to our other two panelists.
Thank you, Jillian. Really appreciated the Rebecca's presentation, and I'm speaking from the unceded territory of the Nkinklatma and Secwepemc peoples from Ashcroft, British Columbia. And we moved to this community about 12, 13 years ago, and a few months after we arrived, by some miracle, my wife was elected to council, and the mayor asked if I would assist with recruiting doctors for the community. When we arrived in the community, we had 5 doctors, and by the time we got our house unpacked and went down to the clinic to register, there was 1. And so we obviously had a crisis to work with. And so I've been working with it since then. I need to be very, very transparent here. I am not a researcher. I don't gather data or anything else. However, I'm an incredible consumer of the work that researchers do. I am always looking at the research, and I'm extracting nuggets from it to use when I'm talking with healthcare administrators or policy people. And I've learned over the years that you can ask your questions in a way that get under the blanket and really cause them to itch and scratch to create change. And so I use that information. So one of the early bits I found was that the primary care pilot projects that have gone on all showed that there was between a 20 and a 45% decline in acute care billings when primary care was active and being really well done. And so when I'm talking with the health authority saying, oh, we can't do that or we can't do this, I said, oh, so you would prefer to waste that 45% rather than have it available for other things. And of course that, but because I have the research, they can't argue with it. And therefore we have to get into a discussion of how are we going to change this and how are we going to make it happen. And so I have a real appreciation of the good things that have come out of COVID. And I know that might not be a politically correct thing to say, but in British Columbia, I've been on the provincial transport and transfer working group that deals with how we move patients all around the province with the BC Emergency Health Services ambulances. And we have been working for 5.5, 6 years, and we have been pushing the 8 ball up the hill. And thanks to COVID, in 3 days, our work went from a paper that has been sitting gathering dust to an implemented policy that was originally implemented for just a few weeks to now being a permanent part of our system. The other thing that we have been working on another team that I'm on, has been how do we find the appropriate uses for virtual care and get that properly instituted into the system. And again, thanks to COVID, we now have that operational. Now, to sustain it, we're going to have a lot of work to do. And so I don't doubt that my task is going to be harder going forward than it's been up until now, but I really appreciate the work that the researchers are doing. And I need to thank Sabrina for some reason thinking I should be part of this. But like I say, I'm not a researcher. I'm a consumer of research, and I consume that research for one purpose and one purpose only, which is to fulfill the mandates that we have in British Columbia for community-based care, to transform from an institutional-based healthcare system to a patient-centered healthcare system. And so I really appreciate the work that the researchers are doing to provide me with the information I need to ask the annoying questions.
Thank you, David. And much like, I was going to say there's no stupid questions, but having watched the news, both in Canada and the US, I'm not going to say that. But there is no annoying questions. There's just necessary questions. So I think that's a better way of putting it in this political climate. Thank you so much. Next, I'm going to call on Rick Gibson, who is based in Nova Scotia. So Rick, if you want to introduce yourself and have a few comments.
Can you hear me? Just checking.
You're good to go.
I'm good. Okay, you can hear me. So yeah, I'm Rick Gibson. I'm Senior Medical Director for Primary Healthcare and the Department of Family Practice for the entire province of Nova Scotia. So kind of like the opposite extreme, we're highly centralized and have one organization representing all family physicians in the province. So, and you know, I find it funny when I'm introduced as a policymaker, because it seems like the higher I go in the organization, the more I find policy still made by somebody one level above me. So, so you know, I was quite intrigued by this project when it first came up, and I'm interested in the results and what they tell us. You know, we're at a different point in COVID in Nova Scotia, in that we're probably in the eye of the hurricane, in that we've had no active cases for the better part of a month, outside of 1 or 2 cases a couple of weeks ago, having had a flurry of activity, and everybody's waiting for the second wave. So, you know, in some respects, where people are at and what they're thinking and what they're expecting is, you know, a bit different from the United States reality. But the United States is to us a horrible example of, you know, what we might have avoided or what we have to look forward to. You know, as somebody in my position, I was interested in the results and the watching what people were worried about and the mood of people from week to week, and how that changed with events. So I was interested in the idea of a survey that was done repeatedly, week after week after week, with similar questions, and watching how things unfolded. You know, nothing in research is simple, and I appreciate that the more I participate in research projects, the more I appreciate how complicated it is. And in this case, it's, you know, how complicated it is to design a survey every week, tweak the questions, run them past a bunch of people, build the survey, put the survey out there, and then get the results. And you know, as it plays out on the ground for the practicing physicians in Nova Scotia, the survey was distributed probably by about 3 different routes at least. So and in the face of a lot of other communication about COVID. So I think, you know, a lot of people either didn't realize that this week's survey was an update of last week's survey and they were supposed to do it again, or that, you know, this week's survey that you did for Doctors Nova Scotia was actually the same as the survey that you just did, that you got from the health authority. So, you know, technical issues there. However, you know, interesting to see. And, you know, I think that, you know, COVID, if you think of COVID as a disease with a natural history, a pandemic as a disease with a natural history, you know, there's the early stage when nobody knows what the disease looks like, how many people are going to get it, how many people are going to die, how are you going to get care, how are you going to get paid, etc. So there's one set of concerns that clinicians would have in the early going. And then as some of those questions get answered, and there's other things appear in terms of, you know, you see patients or friends or loved ones or colleagues getting sick and so forth, then you have different things that you're concerned about. So, you know, I'm not sure in Nova Scotia whether we're in the same sort of mindset right now in terms of people worrying about how they'll get paid or not, because some of those issues have been resolved temporarily. And we managed to, you know, temporarily solve the PPE access issue around the same time as, you know, we really don't need so much PPE temporarily, but, you know, people are worried about where they'll get it from in the future. So, you know, looking at the last point would be that, so, you know, I think the survey could be useful in terms of understanding the time course, recognizing that different jurisdictions are at different points in the time course. I think it also could be useful if at some point we could look at policy approaches across jurisdictions and see how it affected the time course of how people reacted or were affected. So, in Nova Scotia, it took about probably 4 to 6 weeks to sort out income stability for physicians, but then that was sorted, I think. We got paid for a virtual visit exactly the same as an office visit. So basically everybody went over to doing 90% virtual visits, and they tell me they were doing almost the same numbers as they had been doing. So in some respects, their income was stable. And if that didn't work, then they had, a guaranteed income by one of two methods, as long as they promised to consent to be redeployed if they needed to be redeployed. So I say we sort of sorted out the income stability question not as early as it could have been, but relatively early. So it would be interesting to know how that affected the burnout and the anxiety and the other symptoms that people were experiencing as compared to other jurisdictions where perhaps they never sorted out income stability. So I hope that made some sort of sense.
If not, that's what the Q&A session is for, Rick. Thank you. Yeah, I think that it's always challenging being a policymaker. In my first learning series, I put up an organogram of our Ministry of Health in Quebec, and it's pretty much just a full solid sheet of rectangles. I couldn't figure it out at all, and I'm in the system. So I think what's interesting about this project is we have some challenges that I think are definitely overlapping with what Rebecca, and then there's some things that are distinct. And I think our bureaucracy represents a distinct challenge in Canada. And what COVID has highlighted that I'm kind of horrified by as a Canadian is how poor our inter-province communication and strategies have been. So for those of you who aren't Canadian or don't know geography, Quebec borders on New Brunswick, and to get to, unless we go down through the States, to get to where Rick is in Nova Scotia, we have to go through New Brunswick, and they've closed their borders. And technically we don't actually have borders in Canada, but apparently we do. So weirdly, I could probably get to see Rebecca easier than I could get down to see Rick. So there's some fun facts for the people on the call. Okay, so I'm now going to go to our last panel member. Last but not least is Sabrina Wong, who is the director of the BC Pickens site. So Sabrina, if you want to take a few minutes, and then we'll get to the questions. I can see them already accumulating.
Yeah, thanks. That was great, Rebecca. Always great to see it. And so we've been doing the primary care survey in Canada. We've done series 10, just finished. And somebody asked a question about what's going on, like what are the numbers? And absolutely the numbers are much lower in Canada in terms of the responses than in the US. Rebecca, I can't remember how many people every week, but it's at least, I think it started out around 3,000 and you're down to 1,000. So, and in Canada, I think our first survey debuted at about 50 and we've gone up to about 125 and we're down to 25 this week. As Rick mentioned, I think, when we move to, we've now moved to a monthly survey just because we don't want to burden people. And so the numbers are lower, but startlingly, the percentages are very similar to what you see in the US. So we see that 66% of people are still reporting severe and near severe strain in terms of on their practice. We see that as practices think about the second wave and what's to come in the fall, they're very concerned about having enough personal protective equipment and that they want the virtual billing codes to remain. So yes, some provinces have figured it out. Some have, as Rick has said, stabilized it, and other ones are not sure. They haven't heard yet from their government. whether or not those virtual billing codes will remain in place. And then in terms of also preparing, our clinicians are asking for specific guidance on how to manage visits. What are they going to do during the flu season? And they're very keen on how to learn from each other and what are some of the best practices. So we hope that, you know, the last survey just closed. I was not fast enough to get it to you for this presentation, but we'll be getting that done this week. All of our results, the Canadian results, are listed on the SPORE PIHCI website, and I'm sure Jamie or Jillian can type in the website address for you there, but they're all posted. I also want to give a specific shout out to Réseau One. Those are our Quebec colleagues, because Danielle, oh my gosh, I'm blanking, Danielle Shermer, Annie Sandra, and Yves Cotier have, I'm sorry for my lack of French, have definitely risen to the occasion. They have been doing this translation of the survey every single week, as well as sending it out in French, and then also doing the reports. So special shout out to Réseau One, because we couldn't have done it without them. This is truly a pan-Canadian effort, and I don't think would have happened without the SPORE PIHCI network, all jumping in and all hands on board. So really appreciate that. So yeah, I think I'm just gonna leave it at that, and we can open it up for questions.
Thank you, everybody. So I am going to take a look at our questions. It's been a really interesting process. I am going to put in the chat our website, where if you click under on the front page is a survey, you'll see results from previous sessions, as well as links to the Larry Green Center. We don't think we've quite updated it, but we'll soon be putting an update, because this was also something that was done in New Zealand and Australia. What is striking, if you look at the results, is how similar they are, regardless of response rates. It's been fascinating. So, and one of the things we want to highlight is the role of primary care. And while I've always said primary care is key, essential, as have most people who do evaluation of healthcare systems, you know, it is the cornerstone for quality care, you know, an effective use of the healthcare system. I think COVID is making that crystal clear, but are we going to acknowledge that and make it happen before we burn out our workforce and lose more patients to unnecessary healthcare burden? Okay, so I'm going to read some questions. So I think this may have been answered, but I'll let Rebecca and Sabrina weigh in on this. Are you using the same survey in all partner countries? And if so, how does Canada compare? I think, Sabrina, you had some comments on that, but do you want to just clarify about how we might have changed this slightly? And Rebecca, is it, did you mention where else this was besides Canada that you're working with? Were you working with Felicity?
You did too, New Zealand and Australia.
Okay, perfect. So I'll then let you answer the question, how do the questions compare?
So in Canada, we started out having very similar questions. And in fact, we do follow it quite closely. And where we do diverge a little bit is sometimes on the flash questions. But I forgot to mention, and I definitely, it's just because I have no sugar in my brain. The special shout out to the Nova Scotia, the BRIC and NS. Anyways, the Nova Scotia PIHCI network with Fred Burge, Rick Gibson is also part of that. And what we've done is Rebecca does the survey, then I follow a week behind, and then I send it out to the Nova Scotia team, who has some folks on it, on the grounds operations. They look at the questions, we tweak them as a Canadian group working on it, and then we send it on to translation, and then we send it back to Becca's shop. And then they build the survey for us, and then they also, we look at the links, et cetera, et cetera. So that's kind of how it works. Sometimes there's been some questions from, for instance, doctors, Nova Scotia, that they're very interested in. For instance, they were interested in what is the childcare situation like for family doctors and how are they managing that. So that's an example of where the questions might slightly differ, or we add a particular question. So we've really tried to stick closely, because eventually we are going to get around to doing a manuscript on virtual care and how that looks, and then just some of the opinions. So yeah, I don't know if Fred if he wanted to add anything.
I think Fred has to type it in comments since he's not on the panel. And so I don't know, Rebecca, did you want to say anything further about that?
Sure, I'll just say quickly that this is a different kind of research. I'm not really sure what to call it. We made a change in how we did research when we moved from efficacy to effectiveness, right? We had to realize that we needed to change our research design to be amenable to the adaptations required in different contexts. This is very much like that, only sort of on steroids, right? So we have a need to create a cross-country comparison in order to really understand how this pandemic is hitting everybody. That means that we have a shared need and interest in things like PPE and testing, use of telehealth, impact on clinician workforce, impact of health burden on the population, but that how we ask those questions can't be the same everywhere, because there are different payment systems. There are different realities that have to be adjusted to. And so they do change. We're on series 17 now, we included the question this week about should we be opening up the schools, because that's a big topic of conversation here. It's an entirely different time of year in Australia and New Zealand. That question probably wouldn't really make sense to them at the moment, as well as the COVID environment being different for them. I don't see that as a weakness in the study or the survey or the ability to put the information together in the end. It is a methodological challenge. But we do coordinate, and we also in the US, we coordinate with other folks. I'm aware of 37 different national surveys going on of primary care and 14 different local ones. And we actually do share the questions as we come up with them a day in advance with all the others. And we try not to overlap to avoid that taxing on the population, clinical population, but it does happen.
Yeah, I know that when in Canada, when the Canadian College of Family Physicians was considering a survey, Sabrina actually worked with them and we halted our survey so that there wasn't overlap. And I'm going to skip down to Fred has asked a question. Fred Birch from Nova Scotia has asked a question, and I think it's very relevant to what you were just saying about, I'm wondering about the thoughts folks have of other ways to get a read on what's happening from our clinical providers other than surveys. They have so much on their plates, and this is always the concern, right? And I'm gonna, just before I open that up to the panelists to answer, I'm gonna say that, you know, and there's some questions here about sample size and anonymity and all of this and response rates, but I really think this is the only way to do a rapid environmental scan. I don't know if it's the only way, but I think what you're doing is a rapid environmental scan, or almost like a surveillance. You don't get everybody, but it is a bit of a litmus test. And I think that people would, I don't know, I agree with the response burden, but I also think people would like to think that their voices are being heard and that somebody is representing them and advocating for them. So maybe you will get more. I know certainly when we looked at the patient questions with our Pan-Canadian Patient Advisory Council, I don't know, David, if you saw the patient questions, we went over it with them and they're very interested in having a voice because they're very interested in care for things in addition to COVID that they feel the risk is not being accounted for, and they're very, very stressed for. So maybe David can speak to that. So ideas about, I'm sure you've been thinking a lot about this, ideas about things other than a survey that might work. I I'm drawing a blank, but, and David, if you have some comments about the patient questions.
David. You're on mute,
David,
David.
David, you're on mute. I'm gonna put you on a spot and make you go first, and then hopefully Sabrina, Rebecca, and Rick will have time to think about what they want to say.
Like I don't need time to think. No, I think the thing is that one of the things in British Columbia, you know, and it's come up repeatedly in my conversations with people, is we only have right around 200 deaths from COVID, but this year we have, I think it's 1,700 or 1,750 from drug overdoses, and that pandemic of its own has been around for 5 or 6 years and hasn't been getting any focus and stuff. So this is really causing us to do something again that I think is good, and that is to look at the whole system to understand what's happening. In Rebecca's presentation, she was talking about the excess deaths that were happening from various other situations because people weren't accessing care and things like that. And so I think the thing for me from the question is that, you know, we have to be aware of the physician burnout, but we also have to do what we can to encourage the physicians and the healthcare professionals to participate in this, because it's really important. Just as we really have to encourage the patients to participate in this, because if our system is going to change, patients have to stop only going to doctors when they're sick. They have to start working with professionals on wellness rather than illness. And I think that's one of the underlying things that we aren't yet talking about in this whole system, is that we're rejigging the system to be a holistic thing that works with the whole person and the whole community. And so I think that's one of the things that we're going to have to figure out how to do going forward.
Thank you. So
how to get clinicians to be able to give opinions, that's a really hard one. I'm not sure I have a good answer. I tend to attend a lot of town hall-like meetings, a lot of different professional societies so that people can talk and I can gather information anecdotally. It's powerful to be able to put a story to the data that we have, but even though I'm not really convinced that policymakers care about the data, they like to be able to point to it, and they like to have trust in it when they point to it. And I've found that the surveys let us do that. They also appear to be really important to the clinicians in terms of giving them a voice. We constantly get people saying, thank you, this is cathartic, or, you know, at least somebody's listening. We do get about 200 to 250 emails a week from people taking the survey or refusing to take the survey who want to share their thoughts with us, and we tend to include that stuff too. Those are anecdotal ways. I'm not sure about a systemic way to do that.
Yeah, I would just say, you know, people have been having questions around, you know, the response rate. It seems really low, the numbers. And it would be low in the US as well as in Canada, just given the population sizes. And I would say that, you know, we could liken this to qualitative descriptive data. So we're not trying to draw inferences. What we are getting though, I think, is some saturation of the themes. And so I think that, you know, week after week, we continue to see that there's lots of strain on primary care. We see that they're very concerned about personal protective equipment. We see things that, that they're reporting increased patients with emotional health needs. And I would say that this is more akin to qualitative data than it is to trying to understand if there's a statistical significance that is happening between, for instance, what's going on with Quebec versus what's going on with Nova Scotia or British Columbia or Manitoba. Like, I think, so if we think about it in that sense, then what we're hearing from the voices of physicians and nurse practitioners across the US and across Canada, as well as the UK and New Zealand, it's startlingly similar. And I think the kinds of comments that we get also from the clinicians are very similar. And we get comments like this as well, where people are saying, I can't handle this. This is not working for me. So they are feeling stressed. And I think what we're trying to do is to provide a voice for that, not to say that we can generalize to the entire population. But honestly, if these are the people that are answering the survey, they're at least probably maybe the least burdened or the most interested in helping out with research. So yes, it's absolutely a biased sample. No doubt, no questions asked.
Okay, Rick, did you want to say anything about how you're using this information or why you're interested in participating? And, you know, I think one of the reasons why this was done, as Rebecca mentioned at the beginning, is there's no tracking of this. There's no large administrative database across primary care that would give us this information. And even if it's more contextual and just identifying issues, but not necessarily of statistical significance, and that's a whole different lecture on research paradigms that I would need to give. I think that it still is providing information to people who are making really important decisions, who are making those decisions at the moment completely, it's in the dark. And so I think it's incredibly valuable. And as Sabrina says, when you do qualitative research and the same information starts to come out from different sources, you have what's called saturation. So you know that information is consistent and it's something you can use to move forward. So Rick, I'm going to ask you to make a couple of comments and I'll move on to the other questions.
Yeah, I think the child care question was actually an interesting one in that context, because in the early going, people were saying, well, my office is not busy, I can't see patients in person, how am I going to earn a living? And somebody went off and addressed the issue of income stability, and we played around a bit with how, where, when, and why could you access personal protective equipment, and when you're seeing patients, where should those patients be seen? So we came up with primary assessment centers to see patients who might have COVID. So we sort of addressed that issue, but one of the issues that didn't get addressed was, if you have a child and the child needs to be looked after, who looks after the child when you're working? Which, even if you offered to pay people and even if you gave them PPE, when you've created a policy environment in which you can't go from household to household and the in-laws can't come over to look after the kids, then you've created a situation in which parents can't leave home to go look after patients. So, that was an interesting example where, the questionnaire being responsive to concerns that people had, if we had sufficient information about that being a concern, either in one jurisdiction or across jurisdictions, could have been useful in terms of developing a policy approach to that problem. The other thing at this point in time, and again, like I say, we're in the eye of the hurricane, probably we'll see more COVID, but at the moment we're also dealing with, we shut pretty well everything down to deal with this one condition. So we are months behind on x-rays, surgeries, the management of chronic disease. And a lot of primary care providers are very worried about when the patients resurface, how many of them are going to need those things. And for the patients where we've been buying time for the last 2 or 3 months waiting for the x-ray department to reopen, when will we be able to get that CAT scan and figure out why they've been losing weight? So, there's a pent-up demand and a whole bunch of people that have diseases that haven't been investigated and treated properly, and that's going to carry a mortality cost, which may be bigger than the 50 lives that we lost because of COVID. So I'm not the only one around here that's worried that we may kill more people than we cure by being so aggressive about COVID. And the other issue is, it's an awareness thing, but as a family doctor a year ago, if a patient phoned the office and said, I have a cough and a fever, my staff would have booked them in, they would have come, they would have sat in the waiting room with all the other patients. They would have been seen in the middle of the day. I would have seen them without personal protective equipment. I would have told them they had the flu or a cold. I would have, treated them or sent them on their way. And now when the patient phones and says, I have a cough and a fever, it still might be the flu, but now I'm feeling like, wow, my whole approach to that ought to be different. So I don't know how long that's going to hold in terms of people working differently in the future, but it certainly changes the way your office runs, the way your staff deal with patients, the scheduling, the amount of time you spend on a patient, how you use your examining rooms, and there's a huge impact later on in terms of what this has done for people's way of working.
That's fascinating. I think one of the things you highlighted an important point that we're seeing in the universities, because people are like, well, you're working from home, and because the schools are still closed down, now people are not only doing their daytime job, they're also full-time caretakers and educators for their children. So they're actually doing 2 full-time jobs. They're replacing about 3 different people in the running of their household, and that's not being accounted for. And it'd be fascinating, Rebecca and Sabrina, if there was any way to get at how much of this strain is also being a caretaker for kids while trying to do your job, your day job. I mean, I still, when my kids were young, it would be like, I'm going to go to the office to work. It was more like, I'm going to the office to get away. So yeah, that's fascinating. Okay, we have some questions related to that, but first I'm going to deal quickly because there were some written responses to questions about the logistics of the survey. So there was a question about how many people responded to the survey in the weekly survey. And Sabrina had replied to that it depends on the week, and it's ranged anywhere from 25 to 150 in Canada, and the US 3,000 to 1,000. And when you look at the population numbers, that's not a lot of responses, but when you look at the consistency of the answers in Canada, the US, Australia, and New Zealand, I think that those are significant findings in terms of significance, indicating things we need to pay attention to. So, and that also then addresses the question about, given the low response rates, how can you draw conclusions to statistical relevance? So I think we've dealt with that issue, and we talked about what else could we do. And Sabrina has also indicated in her answer there, this is more given a voice to concerns, and much the same way you wouldn't discount rigorous qualitative research that only involves 6 people. This should not be discounted, and the CFPC survey showed similar results. So, and the data is anonymous. There is ethics approval at each of the PI sites, and they're on strong, secure servers. And that was a question about, whether the surveys were anonymous, how you share raw data. We don't share raw data, we only share aggregated data. And it's stored on secure servers. And there's an interesting, I want to take a moment to make a plug. PIHCI is the Canadian delegate for the next OECD survey. This is a patient-reported experience measure and patient-reported outcome measures of patients with chronic disease, over the age of 45 with chronic disease, being cared for in primary care. So what are their perspectives on how they experience care? And the interesting thing of these are questions will be standardized not only across 10 provinces and 1 territory in Canada, which represents PIHCI, but across different, what we call high income countries. So about, I think, looks like they're going to be about 35 different countries. And I was speaking with Health Canada, because they're the ones that made us a delegate. When Sabrina and I were speaking with them about this, they said, well, our budget constraints for COVID, and, are people going to want to do this? And I said, you don't understand. the primary care community really wants to do this because they need to know what's happening with their patients, and they need to know what their preoccupations are because of exactly what Rick mentioned, that we've got issues with care for non-COVID health concerns complicated by potential COVID transmission. And so we really need this information now. Now, the fun part is that Canada, for those of you who didn't attend the first learning series, is actually made up of 14 healthcare systems. I'll let you figure out what the ones are beyond the territories and the provinces. And every single province has had and territory has had a completely different strategy for trying to flatten the curve for COVID. So it's going to be interesting results. And that we'll start pilot testing for that in the fall. But this quick survey is actually, and the work that the Andrew Pinto's doing on health inequities within the PIHCI network has provided a bit of a test, a feasibility test for being able to do those surveys, which will be much more systematic and detailed in their approach. Okay, so I just whipped through answer to 3 questions, and I'm going to go back to our other questions. So one of the questions is that somebody commented in BC, we've solved the problem of billing for virtual care, so doctors can bill for video info, and they want to know if that's true all across Canada, and they're wondering why this is such a problem in the US. So first of all across Canada, I'm going to go out on a limb and say it's true for the moment. We don't know what will happen going forward. We've been pushing for telemedicine in primary care for a very long time. And now suddenly we have it. And like Rebecca said, it's not something you're for or against. It's something that works really well for certain things. It's a tool, just like anything else. So now the question is going to be, how do we move forward in a way that optimizes care with that? So I'm going to ask, I'm going to focus on the part of the question about, or unless somebody has comments from other parts of Canada about why is it such a problem for the US. So Rebecca, got any insights to share?
If I only had insights, that would be great. The US is extraordinarily complicated, unnecessarily so. And many people in the system, I think, have inherited this crazy sort of organization and try to figure out how to change it or fix it and actually struggle to do so. So I don't really blame the people who are in it right now. I think they're doing the best they can with what they have. But it's crazy complicated. So in the US, for instance, whether or not you can bill at all for a telephone visit, first, it matters who initiated the call. So if the physician calls you, this is a billable service. If you call the physician, it is not. Does the call last at least 10 minutes? They seem to think you need at least 10 minutes to have any meaningful conversation. Meanwhile, most inpatient visits are 8 minutes, but you know, okay. They care about the platform you use. Is it HIPAA compliant? Is it secure? They care about so many different things. Well, what about malpractice? How can you really assess somebody appropriately? There are so many, and there are, each practice here has, each primary care practice has on average 17 to 24 different contracts with different payers that all require different things. The loan systems that came out to help primary care in the beginning were so complicated that many practices, to apply for it, actually had to hire an accountant. And if they were really fast and they did that within 6 hours and put in that, they got some support. But if it took longer than 6 hours, they not only paid for the accountant, but the funds ran out and they didn't get anything. We have visits that don't get paid at parity. So if you get paid, say, $85 total for a visit from insurance, you might get $20 for that same exact visit if it's telehealth, or, you know, $3 if it's on the phone. So you could do the same amount of work, but get paid dramatically less. Even as they changed the rules about what you could bill for during the pandemic, the software didn't always keep up with what the rules were. So your process of putting in got rejected and the billing was denied because the software system was not yet ready to accept this new lay of the land. It's been a tremendous burden. One of the unfortunate problems here is there's been so much focus on the video and whether or not you're in the same state, whether you're receiving the call while you're in a medical setting, and therefore we can know about, you know, confidentiality on your side of the call, the patient side of the call versus the clinician side. All these things have become extremely complicated, and they actually forget that there are people walking around on the street who have a need. They need to see somebody, they need to talk to somebody, and they really don't care right now if it's FaceTime and Apple could be doing something with the data, or if it's Zoom and anonymous, or if Zoom could be hacked. They just need help. They talk about how hard it is to support telehealth because so few people have access to broadband. We do have about 25% of our population does not have broadband in their area to even access. Almost 20% don't have tablets or computers or the data plans that would support streaming, you know, those sorts of things. Still, 96% of the population, and that includes our indigent population, 96% of the population has a smartphone. You can call anybody just about anywhere. And we ought to enable that. It's been very difficult. And I was talking to some insurers today who were insisting that they were incentivizing good primary care by encouraging face-to-face visits as opposed to virtual visits. And what I want to say to them is, you must not be living in one of the states where we have 200 deaths a day, because then you wouldn't be encouraging face-to-face visits. This isn't easy for everybody. And we actually know that chronic care is actually, if you're a stable chronic care patient, telehealth visits actually work pretty well for you. If you're part of the worried well and you're wondering what's going on, and if you have it, phone call actually kind of works pretty well for that. And for the people who suffer anxiety, isolation, depression, being sheltered at home makes things worse, and having that outlet is actually a significant support. I don't really know why the US can't wake up to that. I talk about it in just about every conversation I can possibly have. And I try to bring in stories, which is what I do as an anthropologist, is the illness, disease is a biological condition, but illness is a human condition. And if we want to help people with the human condition of illness and health, then we have to be willing to accept both their social and their scientific needs and understandings. And we have yet to actually be able to do that. We're trying though.
Yeah, and I think that is what we're experiencing. You're absolutely right. We think, oh, telehealth will, you know, address. We have a huge equity in access in healthcare in Canada. We have an access issue, period. And they're like, yeah, telehealth, but actually what it's doing is the people that are either rural, there's a lot of rural Canada that does not have Wi-Fi. That's shocking and horrifying, but it's true. This is why when my parents used to live in New Brunswick, I always got a great vacation because my Wi-Fi wouldn't work. So I couldn't have meetings even if I wanted to. And not only did the Wi-Fi not work, my cell phone reception was really spotty. Like there was one part of the house, if I went upstairs and leaned against the window, I could get my cell phone reception. So, and that's a reality for far more people than we think. So what it's done, and because libraries are closed, where they might have gone to get cell phone reception, that it's a big issue. It's a big issue with people not getting the care they need. So it's complicated, it's messy, and it's really kind of sad. And I hope that maybe we can sort some of this out with the work that's being done, including the survey work you're talking about. Okay, so I'm gonna go to the next question, which is from one of our patient partners in the PIHCI network. And she said, can you talk a little bit more about how to rebuild relationships between providers and patients with chronic diseases, given how resource focused during the COVID have been less available? And I know actually this is an issue in the research world too. Like suddenly all the money got diverted to COVID and not necessarily COVID in primary care. And the rest of us are like, these other health conditions didn't just disappear during COVID. If anything, there's a lot of things that were exacerbated. So maybe we can have the panel comment about how to rebuild relationships. And I think Rick spoke a little bit about this, about, you know, getting back into chronic care. I know there's a report out of Scotland that is showing, has already documented increase in mortality for other chronic conditions. So I'll let the panelists go ahead.
I'll start. We have seen that increased mortality. Steve Wolf's documentation of that in the US is pretty significant, showing what they call excess deaths related to people who had conditions exacerbated because of a lack of attention. We see, one of the things you get to see when you do a weekly survey is you see a natural sort of trajectory in some of the sentiments over time, particularly in the open text comments. When COVID first started, everything was sort of a frenetic pace, and how do I set stuff up, and how do I get access for my patients, and how do I do things? Once that settled down, it became, oh my God, am I going to get paid for any of this? Because it's been a month and I'm not getting anything. Once we got through that, it really was, I don't know what to do. I'm not hearing from my patients who have chronic conditions. I need them to understand we have to address those conditions. And they started to worry about the conditions that are unmet. How you establish that relationship is a really important facet. Most of the ways that people did it in here in the US is actually a fairly hands-on approach. They called. They called their patients. They would split up their patient populations, and everybody in the practice would make a certain number of calls at night, or they would email. It was most difficult for clinicians, I think, because they felt like they had no tools for what they were seeing. So there's no vaccine, there's no treatment, there's really no course of addressing symptoms. Everything was kind of anecdotal. It's very difficult if you have longitudinal relationships with people to see them suffer and not to be able to feel like you could do anything, especially if what you consider yourself is a healer. One of the things that I think they forgot, it would be good for them to remember and for patients to remember, that the simple act of witnessing is one of the best healing techniques and one of the greatest relationship builders of all time. So simple outreach to let people know they've been seen or heard. And even if I can't do anything for you, I've witnessed your suffering, and just in the witnessing, you alleviate some of it. That's the best way to address that sort of healing connection. Another is to make sure to be fully present. And this is easier to fake when you're on Zoom or some other resource than it is when you're in person. In person, a lot of docs don't, they just look the other way. But you know, if I were to say, open up my browser while I'm talking to you, you can see in my glasses, I've done something different, right? We all know when postures suddenly go forward and we're focused, that you're typing on something, you're doing something else. It's a surefire way to lose a relationship. There's a trust. And I know that I can trust you if I have your full attention. And I know when your eyes are on me and when they're not. And that's another way in which we can build trust. For the patients, I think it's also realizing that this is an incredible time for clinicians. They don't really have the tools they need to help the people they want to help. They have lots of regulatory and technical and financial barriers to providing help. And it is hard when everything is in crisis mode to remember to stay open to each conversation. So sometimes just simply reminding them, hey, how you doing? Or, you know, interrupting the conversation and saying, hey, I just wanted you to know this is helpful. Or, hey, seems like you're a little distracted. I know you've probably heard this 100 times. but I've got a cough and I don't know if this is allergies or not. And I'm really kind of unnerved by it. And 3 weeks ago, I encountered somebody whose son went abroad in January. And I'm now worried if I have COVID. You know, it's the way we approach conversations, and it's the amount of intent we put into our gaze, and it is the actual witnessing. Best thing.
Well, I
Thanks.
think that the other thing that is part of this is we really have to get back into looking at what team-based care means and how we use that. And because I'm rural, I also think we need to look at community-based care. In our catchment area, we have 5 villages, 4 unincorporated communities, and 23 First Nations communities. And so in that basis, we have to be working together. So we have to have the health leads in each of those communities maintaining contact with the people there, and then sending information up or down accordingly, so that we're able to build those relationships and really make that work. And so and the thing is to my understanding, and again, I'm not a physician, so I don't understand the whole billing process and all of that. To me, all of that is unfunded, okay? and so we're having to look at how we do that. And so how do we give the patients a sense of comfort in that? And how do we help the patients to reach out to do that? And we have to do that within a community context, because right now, there isn't faith beyond community. Like, our community has done very well at this point in time. To my knowledge, we haven't had any COVID cases, and the anxiety level is going way up because now we're having visitors coming in. And so we're really having to look at that. But I think we really have to look at building on the existing relationships that people have within their communities, and then interconnecting those to allow the system to work better. And virtual care really helps us with that, because it helps define when someone actually needs to go in for a face-to-face visit. And for us, that means, how do we find that person the supports they need in order to be able to be transported into that face-to-face session, because that could be as much as 3 hours from where they live. And so, you know, we have all of those things to deal with. But I think it really starts with working with the communities and getting them interconnected and making them a valuable part of the system.
Comments from Sabrina or Rick?
You know, I was going to say, we've, you know, in terms of rebuilding the relationship with the patients, it's been sort of interesting, sort of two-faced messaging, I think, about chronic disease management. Because on the one hand, when you do chronic disease management by phone or virtual means, you're with diabetics, for example, you could have the patients telling you about their blood glucose control and their weight, and maybe they're watching their own blood pressure, so they can be participating in their care and giving you all that information, and you can be relying on all that information because you have no choice. And yet, you know, historically, we've sort of said, well, you have to come into the office and I have to weigh you and I have to check your blood pressure, which is, you know, a bit parental. So, you know, it's an opportunity to let the patients participate more in their care, but it also sends a bit of a message about, you know, I don't really need to see you at all. And there are a lot of circumstances where you do need to see the patient. And I think of sort of countless examples over the years where a patient came into my office ostensibly for one condition. And I, you know, within 10 seconds of walking into the room, I looked at them and realized there was something else much more important, whether they knew it or not. It could be the basal cell carcinoma in the middle of their forehead, or it could be the fact that they've obviously lost about 30 pounds and weren't going to mention that, or, you know, that they're you know, horribly depressed and they've booked an appointment about a cough or something. So it's you know, I really worry about the idea that you can do things virtually, or that, and the other messaging has been, well, you know, some of those tests that we used to say were really important can be put off. So, you know, how often do you check an A1C and how long can you put that off? And, how often, but the pap smears, which are all getting put off at the moment because people don't want to come in. So, and just, and the final comment is just, we've gone from the idea that being in public or being in a doctor's office or being in a mall or being in a store is a risk. And I don't know how we're going to get back to the idea that people think they can go to the doctor's office and it's not a risk or a hazard to their health. I mean, it is, and we got to deal with that. But you got to figure out what's the balance of risk. You're there for a reason to get something that you need to get your health looked after. So the chance of getting COVID from the person next to you, in Nova Scotia, population of 1 million, we had 1,000 cases, documented cases of COVID over the 3-month interval. So assuming they were all active at the same time, your chance of getting, being next to somebody with COVID was 1 in 1,000. The odds are most of the people in the waiting room with you don't have COVID, and yet people are scared to sit in the waiting room for a few minutes with somebody, or scared to get closer than 6 feet to somebody in the grocery store. So we need to get back to people feeling safe enough to go to the doctor's office and actually get seen for something else.
Well, thank you, Rick. And I think that leads nicely to the next question, because the question was, what can patients do to help primary care right now for mutual benefit? So is there a role for patient education and optimizing population and physician health in this time? I feel there's much confusion among patients on how or if they should be accessing primary care. And I certainly know from our patient advisory council, when this first started, we had a patient that this wasn't optional care. If she did not go to the hospital, and then she's on the line, so she'll recognize the story, she would go blind. So, but it wasn't just a matter of like no contact till you get to the hospital. She lives in a rural area. So it's the travel there, staying in a hotel, going to a hospital. And so what's the protocol? And it seems like I've certainly seen this in a lot of different situations. It seems like the protocol, it changes by the minute about what we should do to optimize safety. So thoughts on the other side of the desk and what can be done there to help this, what is obviously a very tense, stressful, and probably not very functional system at the moment. I'm just going to leave that wide open. So I don't know, Rick, you want to, we'll do reverse order. You want to take it first?
I'll dive in there. I think it's been a useful exercise in the sense of people need to think about their relationship to patients and what they ask of patients. So, historically, some doctors would think nothing of insisting that the patients come into the office every month or two for prescription refills for something that's, stable, and they've been on the same drugs forever, and the patients would come and their office would be badly run, and they'd sit there in the waiting room for long periods of time waiting to be seen for a 2-minute interaction with the doctor. So, I think this is a good opportunity for patients to question, why does the doctor insist that I come into the office, to be seen for 2 minutes for something which has been the same for 10 years and for a drug that hasn't changed? So why not refill the prescription for a year? Why not, accept my self-reporting of my blood pressure rather than insisting you come into the office for that one blood pressure in 365 days and assume that that's reflective of what's really going on? So it's an opportunity for patients to question that. I think it's an opportunity for doctors to think seriously about how they run their offices. And how many patients, is it a good thing you've got lots of patients waiting in the waiting room, or is that actually a bad thing? Do you need to look at your scheduling practices? Do you need to cohort the patients with infectious diseases at the end of the day and, usher them in quickly into an exam room and clean the exam room after they've left and not have them sharing germs in the waiting room, et cetera? So I think it's an opportunity for people to rethink some of that stuff. And if virtual care stays, it's a good opportunity to think about which things can you look after without face-to-face contact, and which things do you really need to see the patient for. So I'll stop there.
Thank you. Comment, Rebecca, David, Sabrina?
Sure, I'll make a couple. One is that it reminds me, this actually reminds me of a piece Don Berwick wrote, and I haven't read it for maybe 15 years, but it still applies, and it was remarkable. He talked about changes in firefighting, was just talking about it earlier yesterday, and saying that, you know, now we know when we're fighting wildfires to dig out areas so that we cut off the fuel to the fire, and that's one of the ways to stop it. But that had to be discovered by somebody, and we didn't know that for a long time. There was a very famous case of a bunch of firefighters who were battling a fire. The fire was winning. They were trying to get away from it, but the fire was advancing faster than they could get away, and they ultimately perished. And when they were found, they all had their 40 pounds of equipment each that they were carrying. And the supposition was if they had let go of those 40 pounds of equipment that weren't helping them at all, they may have actually had the speed and energy to get away from the flames. And he referred to medicine as the same way, that we have these tools that we've been constantly carrying, and we're in a new situation, and we refuse to see that they don't always help us, and we hang on to them till the bitter end. In the US, I would call that fee for service. But what it makes me think about is truly just the way that the 9/11 changed the way air travel happened forever. There was no going back to normal. It simply changed how we thought about travel and security. I think it's also true that COVID has caused a rupture in thought. There is no going back to normal. It simply changed the way we understand how health is won and lost. And it's changed the way we understand how to best take care of it. And while it's possible that it is necessary to go in and have your blood pressure checked or to have your blood sugar checked because, you know, people lie or they misrepresent a little because they don't want to look bad, it's also possible that not having to go in once a month for your prescription renewals is an okay thing to let go. I think what we're facing is that we don't have a good understanding of what are the things that we've been clinging on to that no longer support us. And that's what's being challenged right now. We really need to let that go. One of the biggest challenges that I was talking to my colleague Kurt about is this rupture in thought. So bear with me, it's only going to take a second, and I know you might cringe when I say it, but during the Enlightenment, right, we had the rise of a medical practice because we fundamentally changed how we thought about health. And we used to think that the only way to help health was to address the problems of the soul. And during the Enlightenment, we understood that there was an organism in the person, and we had to address the organism. And we created a way of doing that and a scientific thought for that. Primary care is another rupture in thought. And primary care represents our understanding that the biological isn't the only way that health happens. That whole people have all sorts of parts to them, biological, psychological, spiritual, emotional. We need to address all those things. I think if anything, the colossal failure in the US to deal with COVID represents a rupture in thought that shows that health is not won and lost in individuals ever. It is a collective ordeal. That we have the biological, we have the social, and we have the civil society. And unless we deal with all of those things when addressing health, we're never going to be able to solve any one of them. So I think some of those ways that we practice, they've been developed around individual one-on-one transactions. And this ought to be a point at which we understand it's not about individual one-on-one transactions. And when we start to understand that, we may realize that some of the tools we've been clinging to no longer serve us. I think that's the kind of education we want to understand. This is an unknown. I get people being afraid. I get that you're more likely to encounter a person with COVID in a practice waiting room than you are in the grocery store. I mean, I can understand that, right? You're also probably more likely to encounter people who are being aware of their personal environment and protection in a practice when they're sick than you do in a grocery store. So there are varying ways in which we can look at those things. It may be good. It may actually push us away from volume, and not volume over value or any of those stupid little sayings, but actually thinking about how we understand how health is won and lost in context. So I like a lot of things you bring up, Rick. I think we also, there's a big challenge to realize what are the things that we clung to, like the idea of needing representativeness in a sample in order to do anything. I don't know, the US has 320 million people. How you get a representative sample for anything in a population like that, it is beyond my imagination. I think if you have a few thousand and if you do it repeatedly and it's always the same, you can feel pretty comfortable. It's good enough to move forward with. Jillian.
Thank you. And so I teach translational science and I teach different research methods. And one of my favorite slides to put up is this saying, don't cling to a mistake just because you spent a long time making it. I think we have a tendency to not want to figure out something new. It's very human. So I think, and that is, you brought up an excellent point. By the way, I want to mention to our webinar attendees, you have two options when you put a comment. One, it just comes to us, the panelists, and the other comes to panelists and all attendees. So if you're making a comment you'd like to share with everybody, make sure you pick panelists and all attendees. Because one of our attendees commented to the panelists about this notion that has been integral to primary care and doesn't get remunerated or funded, and that's prevention. I think COVID has made it crystal clear that there has to be a far greater emphasis on context, prevention, and promotion of health, and not just be a reactive, oh, you've got a symptom, what Band-Aid can we put on it? That's just simply not sustainable, which we've known in primary care for a very long time. And only now are we like, oh, we need to strengthen people's immune system and they need better food and they need healthier working conditions. So it's in primary care, we're like, yes, we have about 100 years worth of research to show that's the case. So it's fascinating to me that this might be a crack in the wall to let the light in, and maybe we can widen that crack and move forward. But I know we got a lot of work ahead of us. So David or Sabrina, do you want to comment on this as well?
Yeah, I mean, I agree with what Rebecca has said. I think that it's a time for us to reflect on what is working, what has worked, and where we ought to be going. And I think patients, society have a big role to play in that. So, you know, again, the Medicaid prescription renewals, do we have to go in all the time? And I think there's a lot of things that can come out of this in terms of, okay, when do I need to be going to see the doctor or nurse practitioner or whatever? When do I need to go into primary care from patients' viewpoints? And actually reflecting on that. And I would say that, you know, in talking with patients, many patients over many years, those ones with the chronic conditions often have a very good sense of what's going on for them in their body. I mean, I've had to do many discussions with people about, you know, maybe you shouldn't be trying to titrate your own, you know, heart medication. Maybe you should go and see the doctor about that. So, you know, as with everything, nursing, primary care, it's both an art and a science, and it really depends on, one, the relationship and trust that you have with that person, but also knowing yourself and knowing your body. And I think there's a lot that patients could be partners in helping us to understand that part. And I think there's been a lot of reevaluations done. And certainly we see it in the comments of the survey. So we know that primary care plays an extremely important role in terms of, you know, the patients have no clue. They're going in and then, you know, primary care needs to order the diagnostics, and they're having problems with the diagnostics and coordinating the care, or they can't get the person in to see mental health or do the referrals to the specialist. So there's some major problems where you can't just do it over the telephone. You can't just do it in a Zoom call. And so, you know, we now have a kind of a new set of problems, and we have to try to pivot to understand, both from the patient's point of view, but also from the primary care point of view, you know, what are these things good for and what are they not good for? And I still think, you know, we weren't trained as physicians or nurse practitioners or whatever. And so you do have to deal with a stable of experts to help you out with your health, which is both, as you said, physical, but also emotional. And so everybody plays an important role. And I think there's lots of learning that we still need to be doing. And I think patients have a big role in helping us understand how to better care for them. With them, I should say.
Yes, with them. Not on them or at them or for them. Conjunctions, those verbs are important. David, what do you think?
One of the things that I think, and I don't think anybody is doing this at this point in time, I think that we have to look at recreating society as a whole, because society has sunk to the lowest common denominator, and there is really no social order, and there is no respect in the system in so many different ways. And you know, one of my thoughts is that right now we're in this absolute panic and rush to find a vaccine. And I would love to see in Canada, where all of the universities and all of the researchers decided to get together and work on it together. And if they find the vaccine, that it gets patented, but the patent gets held for the people, not for individuals or for a corporation. And that in the sale of that vaccine, there is an amount built into it that goes back to support the research, but that we take the incentive out of it for the private companies. Because right now, I have a real concern that a vaccine is going to be found and it is going to be inaccessible to 90% of the world's population, simply because of the fact that we have monetized everything. And, you know, speaking of monetization, I feel it's an absolute sin that we are training doctors and they are spending the first 10 to 12 years of their practice paying off their student debts. That is just wrong.
Thank you, David. I think there's some really complicated issues there. I think everything you mentioned requires its own multi-day seminar there. But we need to think about these issues. We need to push the envelopes on these issues and not just accept a sort of, you know, like Rebecca said, we can't continue doing what we did all along. This is a really good opportunity to examine what works and what doesn't work, and why are we expecting things just because that's the way it's always been done. So one of our final question, then I have a couple of announcements, and then we'll be ending at, we're done at 1 p.m. So this was actually originally a question for you, David, but I think that others can speak to this as well. And in addition to you, is, you know, describing your role as a patient partner and what has been to this project, but in general as a patient partner. And I'm just going to add to that and also Hannah, there was a clarification from the last to say, you know, the way patient education as sorry, can help the situations to encourage patients in being vocal to questioning the way things are run. First of all, I give public lectures on patient safety, specifically for prescription medications. You should always question the way things are done. You should always have a list of questions in any interaction with the healthcare system, and ask, in addition to Rebecca's question, like, hey, how are you doing? And say, you know, what's not working in this way for you? Because a lot of times people make assumptions. People make assumptions about the safety of prescription medications. They make assumptions about the effectiveness. They make assumptions about who's keeping track of what information. They make the assumptions of what physicians are able to do and what information they're being given. fragmentation of information is a huge issue in every one of our systems. I think we had a project once where we provided the list of medications to our physicians of all the medications their patients were on. I think the physicians never got a bigger shock in their life. They had no idea their patient was seeing 3 other physicians. So you should question. You are our biggest ally, both for research and clinical care, because you're the voting population. We are a minority, both as researchers and healthcare providers in the system. Believe it or not, we're the minority. And we always get, oh yeah, you're a researcher. You always want more money to do your work. Ah, you're a clinician. You're in the upper 1%. What are you complaining about, right? So this is the reaction we get. So we absolutely need, want, and appreciate you as an advocate for stronger primary care system. And please, please, please question everything all the time. My clinical colleagues might at some point kill me for that, but it's so important. This is your health. This is your life. You only get one of them. So, you need to optimize it. And we want to help you do that. But yeah. And so, David, you want to talk about, because, why you're a patient or around your patient partner role in this network and in the project?
Well, I think it started for me 20 some years ago when my GP had several cancellations, and he said, I'm going to do something I don't get paid for and I haven't done in years. I'm going to sit down and we're going to take this time because I've got an hour. We're going to go through a complete family history for your thing. And out of that, he started to have me on a set of PSA tests. And I was only in my 40s. I went in about 6 months later, and I was absolutely shocked because it looked like a bank when the inspectors were in. And so I mentioned that to him, and he says, well, you're right. The inspectors are in there auditing my office because I'm prescribing unnecessary tests. And I said, oh, what unnecessary tests are you prescribing? And he says, your PSA test. And 3 years later, the audit stopped when 4 of the 5 patients that were under 40 were doing that had treatment for prostate cancer. So I'm a prostate cancer survivor because of a doctor taking the time to look at the whole of me rather than the situation I came in for. And so that really got me supporting him, and seeing how the system mistreated him for him doing his job inspired me to really get in and work at this. And that's what I'm still doing right now, is trying to find that balance. I think Rebecca was the one who said that virtually everyone in the system that I have met is really committed to doing their best, and they're working at it. But there's all kinds of things in the system that prevent them from being effective. And so I try and identify those things and ask the questions that will help us to change those.
Sabrina, do you want to talk a little bit about the working with patient partners? And then I'm going to actually just actually what I'm going to do, sorry, I'm going to do something else. I would like each one of our panelists to, forget it, Sabrina. Now, each one of our panelists to take 1 minute to summarize their thoughts on this. Before we do that, I want to let you know that we do send out an evaluation to all attendees for this session. Please complete it. We use it to develop further seminars to meet your needs. And also our next seminar will be August 11th. The advertisements will be going out shortly. We have 3 more seminars, 3, I think, yes, 3 more seminars, I believe, Alberta. Our next one's Newfoundland, Alberta, and Quebec will be giving their seminars before the end of the summer. Jamie has posted the website address where you can go and look, and these recordings will be available to you. And I wanted to thank not only our panelists for taking the time to do this, but also our funders. CIHR is the main funder for the PIHCI network. Every single network across the 10 provinces and 1 territory have partnered funding and matching funding. So we'd like to thank those partners. And I'd also like to thank my team that helps make this happen and does all the work behind the scenes. That's Jamie Demore, who is the Network Coordinating Office coordinator, and Stephanie Hindle, who is doing a summer internship with the Network Coordinating Office. And of course, Sabrina Wong and O'Neill Badarachi, who are my 2 research and clinical leads for the Network Coordinating Office. So with that, I'd like my panelists to each take, we'll start with Rebecca, and each take 1 minute to give me some concluding thoughts, and then we'll sign off.
I love that you thanked your funders. I want to thank mine. They're not here, so they don't even know it. But the Morris Singer Foundation and the Samueli Foundation, true to form, there was no federal funder or nonprofit in the US that I could find to actually fund this work. We were just doing it out of compassion. So I'm really appreciative for them. And actually, that's what I would want to leave the note on, is compassion. I think working during a time of crisis requires a lot of compassion. We tend to question things when we're trained to do so, and we forget how hard it is to do the simplest things right now. So compassion for the patients who are getting all kinds of conflicting information and who are just nervous and trying to figure out how to make their way. Compassion for the clinicians who are right now doing a terribly hard job and are trained to take care and fix, and there is nothing they can really fix right now, and simply witnessing is a terrible burden to carry. And compassion for the policy folks who I think really are trying to do the best they can, and sometimes are just trapped within a system that doesn't do them justice. If we can work with each other and figure out how not to care about what previous standards were, and how just to figure out how to share information, not be worried about risking looking foolish or failing, I think we're gonna come through in a better place.
I 100% agree. Thank you, Rebecca, and thank you for taking the time to be with us. Rick, final thoughts? And I'm going to ask you to make them speedy because we are almost out of time.
I think it's been a very interesting project in terms of finding out how a single common event affects practitioners across a wide variety of geographies. It's sort of interesting to see the commonalities of their response, and also interesting to sort of think about the challenges of doing this kind of work while it's important.
Thank you. That was speedy and great. Okay, David, and I'm going to let Sabrina have the last word.
Just thank you for allowing me to be here, and I really appreciate it.
Thank you. Your perspective, David, was really interesting, and we appreciated having you. And just a reminder, everybody that's a patient partner, they do have other full-time jobs. So this is always a very generous contribution on their part. Sabrina, last words.
Yeah, just thanks a lot for everyone, and thank you especially Becca for this idea and having us join in partnership in Canada, and thank you to all the Canadian partners across the country. So this recording will be available later on, and so yeah, thank you. It's great.
Thanks everyone. I appreciate you taking the time out of your day to attend. And I hope to see most of you in a couple of weeks when Newfoundland talks about the projects they've been doing in the East Coast of Canada in a time zone that does not exist in the United States. So have a great rest of the day, and thank you again.